volume less than 35 mils per meter squared equals the threshold for low flow. And then the other one, which are the sickest patients, are the low flow, low EF. So that's the classic low flow. So basically the flow is low because the pump is down. And these are the ones that are pretty obvious to most of us. So that's a low flow condition. So we understand low flow in the context of dysfunction, low flow in the context of small chambers, but there's other low flow scenarios. And that's the point of this, is to get there. So when you're thinking mixed valve disorders, you've got to think about flow. So what are the things, the scenarios that generally reduce forward flow? Okay, there's a whole bunch of things that are listed, right? Some of these are obvious, some maybe not so much. So the top left here, the small LV, we just talked about that one. That's an example of paradoxical low flow, as we see in AS. Pronounced remodeling, same thing. A thick chamber takes away volume of the ventricle, leads to a lower stroke volume. Mitral regurgitation is an important one because that's the idea of lost flow. So the EF can be normal, but that flow is not going forward out the aortic valve, it's going backwards into the LA. So that's low flow through a mechanism of lost flow. RV failure, that's really just, again, we're talking left-sided dysfunction. So you don't preload the LV, you have a low flow scenario. The one that gets confused a little bit is mitral stenosis. So in general, mitral stenosis is not a low flow condition. I've heard lots of fellows mention, well, it's low flow, it's mitral stenosis. So just the mere presence of mitral stenosis doesn't create low flow, because if it did, you wouldn't have high gradient, right? If the gradient goes up, that's because the flow is maintained. So at the extreme version of mitral stenosis, yes, it is possible that it may impact flow volume. But generally, that's not the scenario. So don't automatically assume mitral stenosis is a low flow condition. Where mitral stenosis gets fascinating is in sort of your dialysis patients, when you change volume, big swings day to day, or those with a shunt. If you have a shunt and you can actually impact the shunt, and we've got a few cases of this in the lab, where you can actually occlude the shunt, open the shunt, and watch the effect on the mean mitral gradient. It's impressive. So, but in general, mitral stenosis is not a low flow state. TR can be significant TR, same reason of RV dysfunction. You depend on the preload to the LV. If it's not ejecting the RV or if it's going backwards in the RV, that's a low flow condition. So again, this is the emphasizing in the multi-valve, mixed valve dysfunction, you've got to consider what is the flow that's hitting this valve that you're trying to quantify. Okay, a couple of different examples to sort of hammer home this notion of flow dependence. Sorry, turn on my phone. That's YouTube. They're calling. They're happy. All right. So let's look through a case here of aortic stenosis. 75-year-old with AS, heart failure symptoms. How does the LV look? Systolic impaired, please accept that. We have an LVOT VTI, we have a CW. The basic math is a stroke volume of 40 mils, a mean gradient of 46, a valve area of 0.4. So what is this condition? Anybody? Do we know what this is? Pardon me? Severe AS?
Can you raise your voice so we can hear
Yep.
you?
Okay.
And with confidence.
So EF is down, mean gradient is 46. How do you get a mean gradient of 46? You need flow, and you need an obstruction. Okay? So, but in this scenario, you've already got 46, which is one of the thresholds for severe. So despite a bad ventricle, you've still managed to hit this metric. So this is low flow, normal gradient, severe AS. This is sort of the worst AS. If you can manifest under low flow condition features of severe AS, that's a really bad one. Okay, this valve area will be very small, and it is 0.4. So you don't need dobutamine for this, right? If you've met the standard for severe and your low flow, you don't need more flow. It's not going to change anything.
Did you ask them if they would do dobutamine?
I just said you don't need dobutamine. But I could ask them now, but that would be cheating. I just said you don't need one. All right, we'll go through a couple more. Different case. EF also impaired, stroke volume is down, different velocities now. Okay, now I've given you the Doppler there, peak velocity 2.7, mean gradient 16, so neither of those meet the classic flow criteria for severe AS. Valve area 0.94, okay. What is this aortic valve condition? Is this severe or not?
Seems like low flow, low gradient. I would say I would do the butamine first cycle.
What would you hope to achieve with the dobutamine study?
Increase the gradient.
Okay, so you'd like to demonstrate that if you augment the flow, the parameters of severity start to look worse, aligned with a more flow condition. Okay, reasonable. So this is that. This is the augmented dobutamine study. And what happens is the EF goes up a little bit, stroke volume goes up a little bit, peak velocity goes up just a little bit, but the valve area goes up a lot. So you've revealed that it was from 0.9 to 1.4. So one concept is valves only open as much as they have to. If it opened to 0.9 and got all the flow out, it's not going to keep going. So when it needs to open more under a higher flow condition, it does. So that's the idea. So this is not severe stenosis, revealed by dobutamine. Low flow, low gradient, non-severe if you wanted to give it a label. Okay. Another one, one more of these. Bad looking ventricle. There's the rest Doppler, same velocity, 2.7, mean gradient of 18, stroke volume 45. This time the valve area is 0.7. Before it was 0.9, now it's 0.7. So again, is this that situation where the valve only opens as much as it has to? Flow is so low that it doesn't need more than 0.7 to actually eject the stroke volume? Don't know. Similar scenario, this is where dobutamine, augment flow, see if parameters change, is useful. When you do that, velocity goes to 4.1, gradient goes to 40, stroke volume goes up a little bit, and the valve area effectively change stays the same. So now you've met all the severe criteria with augmented flow. You can be confident then this is low flow, low gradient, severe aortic stenosis. So this is not necessarily mixed valve disease, but it's sort of hammering that message of you got to think about the flow when you evaluate mixed valve dysfunction. So this is a common scenario. This is AS with AR. Okay, we know there's stenosis. We know there's a leak. On this scenario here, if you could just, you probably can't read it. I can barely read it. Peak velocity, sorry, mean gradient across this valve is 61 with a velocity of just about 5 meters, but it also leaks. So this comes up sometimes. Well, there's a lot of flow. There's a lot of AI. That's giving you augmented flow, maybe supernormal flow. All that backflow has to go forward again. We've got so much flow through this valve. Maybe the valve is only a moderate, maybe a moderate to severe, but we're giving it so much flow, it looks like a severe. One notion there is that the ventricle doesn't care. The ventricle doesn't care where the volume comes from. If it's AI induced, if it's high flow because of dialysis, whatever. If it is a mean gradient of 50 plus per beat, that's work the ventricle has to do. So at the end of the day, the ventricle's got to move a mean gradient of 51 beats, 51 millimeters mercury per beat. So the hemodynamic load is significant stenosis. Now the two examples on the right, so let's say you've got a high gradient with a large AVA and there's a lot of AR. Your mean gradient's 42, but your valve area is 1.2. And this is where the importance of an accurate valve area really matters. Serial studies, you got to get the LVOT dimension right. You got to get a good PW in the LVOT to get a good LVOT VTI that you truly believe. And if you can reproducibly serially evaluate AVA, you get a 1.2, you're pretty confident this is a mixed stenosis and regurgitation, but the AS by itself is probably not severe if your valve area is opening to 1.2. Other hand, same velocity and the same mean gradient in a different patient, but your valve area consistently is 0.8. Well, here it doesn't really matter that the flow is augmented by AI. If you've got velocities over 4 meters, mean gradient of over 40, valve area 0.8 or less, you still call that severe AS because you've met the criteria. You don't change the criteria simply because there's some AI. That make sense? Okay. A little more diagnostically challenging. This is a short axis. The lights are a little bright.
Say something about
Please.
mixed lesions.
Mixed lesions are difficult. And you have to think also from a pressure as well as volume overload. So it's not only the pressure, it's the volume overload. So these ventricles could be larger than expected for an aortic stenosis. Patients may become more symptomatic, and you won't have a severe AS than severe AR. So you have to kind of, keep that in mind. This is an entity that there isn't much in the literature about. So keep those in mind. Whenever you have mixed lesion, MS, MR, TSTR, AS, AR. Keep them in mind because it's both a pressure and volume load, and the ventricle reacts differently to it, and patients may be symptomatic earlier. The other point is there is a rare, not rare, but infrequent, whenever you have a lot of aortic regurgitation, pulse Doppler in the LV outflow tract could be high velocity. So if it is 2 meters and above, you have to correct for the gradient, right? You cannot ignore V1 squared. So, and that could become 10, 15 millimeters of mercury, you know, for you to apply the Bernoulli equation.
So maybe one of the more senior fellows or an imaging fellow, comment on this short axis mitral valve and the diastolic orifice of the mitral valve. That's what I'd like your thoughts on. I know the lights are a bit bright. It may not project as well as it should. Anything look abnormal? Issa, louder.
The mitral valve looks tethered.
Tethered, okay. Talk about, look, so I'll orient everybody. The anterior leaflet is above, the posterior leaflet is below.
The top of the smile is the anterior leaflet.
Yeah.
The bottom part is the posterior leaflet. And you can see that the valve looks tethered posteriorly. Like the whole, the two commissures and the opening of the valve, they're more posterior
So that's
instead of more central.
the orifice. This is anterior leaflet, that's posterior leaflet back there. You're right, the opening looks weird, right? It should be a circle in diastole. The valve should be, leaflet's fully separated, near circular. There's reasons why it doesn't look like a circle sometimes, right? Acquired stenosis, obviously. Rheumatic tends to have commissural fusion, so we're in the cusps. They get fused, subvalvular apparatus as well, or calcium. This valve has no calcium. The commissures, take my word for it if you can't see it, are wide open. There's nothing wrong with the commissures. There's no calcium. Maybe it's a congenital parachute, something funky, but that's not this lecture. So there's something weird with the anteromitral leaflet. So at the beginning, I alluded to sometimes valve 1 causes a problem with valve 2, and valve 2 is the innocent bystander. This is an example of valve 2 is the innocent bystander. Right, good. So this is the short axis view of this. Okay, so that's a peristernal long. You see an enlarged aortic root. You don't see the color yet. You might see an abnormality of the aortic valve leaflets, but look at the anteromitral leaflet here, and it kind of curves, and this is the same valve I showed you. It just never opens. So what's causing that? Yeah, it's the hydrodynamic effect, and now you can see the prolapse of this leaflet, and you can imagine there's a big color jet hitting that anteromitral leaflet and preventing it from opening at all. Okay, and that was described by who? Right, this guy with the mutton chops. Long time ago. And this is another example. This is probably easier to see, and look at the effect of the anteromitral leaflet. So this is sort of a pseudostenosis, if you will, but it does affect anteromitral leaflet flow. LV doesn't seem to care because it gets all the flow from the AI anyway. It's still getting filled easily just from the wrong valve. But this gives you what finding? Clinical exam finding. The Austin Flint murmur, so named for this guy, the diastolic rumble. It's been debated whether the rumble is actually the AI flow against the anterior leaflet or it's the mitral flow trying to get in through a closed anterior leaflet. I don't know the answer, but that's the phenomenon is the anterior leaflet has been closed by AI. You have this sort of pseudostenosis of the mitral valve, but truly a very eccentric AI jet that impacts valve number 2.
A tough one from an auscultation.
Very tough, yeah.
These are two diastolic phenomena, right?
Tough. Thankfully, we have echo. If you're not sure what's happening, there it is upside down. And this is, of course, what you would expect on the flow. Very eccentric jet. So we've seen this a number of times in our echo lab and absolutely in our valve clinic where you do the peristernal image, you see the anteromitral leaflet not open, and you know there's AI long before you listen to the patient or you put on the color. In theory, we're listening to the patient first. In reality, sometimes the echo happens first in certain specialty clinics. But you know the AI is there without any color, just from the morphology of the other valves. Okay. AS and MR, that is a real challenge, right? Easy to go backwards, hard to go forward. So that is something that usually is associated with some profound symptoms and some therapeutic challenges. This is somebody we saw in the valve clinic a while ago, 83-year-old woman, remote cab. She's got this MR, so thickened calcific mitral valve, fairly impressive color Doppler of the MR. She's got a dense jet of CW of MR going backwards, almost as dense as the flow forward. And on E-wave, she's got an E-wave over 150 going in. So many features of severe MR. The challenge is she's also got an aortic valve that looks like this. All right, so she's got a thick calcific aortic valve. I think this guy plays as well. She's got this CW across the aortic valve. Now here's the challenge. This is that loss flow scenario. You know she's putting a lot of flow backwards. The EF is basically normal. She's got kind of an early peaking AS jet. It's only 3 meters and a normal LV of normal size. Does this mean she does not have severe stenosis? So this is the diagnostic challenge. She has severe MR, yes. She might have severe AS. How do we resolve this? Stroke volume? Is that what you said?
Yeah.
Stroke volume's low. Stroke volume is, say, 40 mils out the LVOT. Indexed, it's 25. But you know that because she's got significant MR. So she is low flow. So she's a low flow, possible severe AS. How do we resolve this? Can we give her dobutamine? Yeah, so simple teaching, if the EF's normal, there's no role for dobutamine, right? So remember, dobutamine is a low ventricular function test. But if EF's 60 and you make it 80, you've established nothing. So you don't give dobutamine for a normal EF. But the other problem is, that's why you also don't do dobutamine on the paradoxical low flow. But here it's even worse because likely you're just going to increase the MR. So let's say the EF was 30% and she had severe MR. The chances of getting a diagnostic dobutamine are really bad because you're just going to augment the MR probably. Okay, so dobutamine's super unlikely to be of any help. Okay, CT. What would you hope to get from a CT? Planimetered valve area? Yeah, so the planimetered valve area, just comment on that. You know, you might get a 0.8 or a 0.9 on a planimetered valve area. The problem is that notion valves only open as much as they have to. So it could have opened to 1.2 under different flow conditions. You don't know that. But the CT valve calcium score is very helpful. So in a woman, if it's over 1,200, let's say hers comes back at 2,500, that's easy. That's severe. That's reasonable. It's not a slam dunk, but the preponderance of most of the data would say that's good enough to say this is severe AS as well. Now you've got your therapeutic challenges. Which one do you go after? Pardon? Aortic first, always, in her? Why?
Well, it depends on the mechanism of the MR.
Her.
Secondary MR, then I would go for the aortic first.
Okay, is she secondary MR? You've seen 2 echo images. She's got a normal EF. I'll tell you there's no regional dysfunction. She might have atrial FMR maybe, but big atria.
I will go for the aortic.
Yeah, so the simplistic thing is very difficult to do a mitral valve edge-to-edge repair in somebody with severe AS because you're under this constant pressure load issue. So that's a tough thing to do. TAVR in general is a more discrete therapeutic expectation of pure performance. You do a TAVR, you're going to go from AS to no AS, usually with no leak, you're fixed. That problem at least is fixed. Edge-to-edge repair, calcium, all these things, so no. You're very unlikely to have a good edge-to-edge repair in this patient, probably just from the calcium alone. But most of the time, it is a TAVR strategy first when there's concomitant severe AS and they fit for TAVR. Yeah. Yeah, so that is more challenging. The calcium score comes back at, say, 1,200 for female, so let's say it comes back at 800. Now, that's tougher. That's a tougher scenario, and that's where we have a data void, and you don't know what to do. So you don't have great data that it's AS. You might ultimately be considering a TAVR for somebody who has moderate to severe, or maybe moderate AS, and there really isn't a great diagnostic tool to tell you if the calcium score is less, but you would wonder if that's the right thing to do at that point. We have done that. We have sent somebody for TAVR with a borderline, but a clinical exam that is consistent with stenosis and symptoms that are consistent with stenosis, and you've done your best to untangle this web. And they have gotten better. And the MR, does the MR always get better? No. No. If it's primary MR, it often doesn't change at all. If you've got, busted cords or a prolapse or something, you're not going to do anything to it typically. Functional MR can get better, but it's less dramatic than you would think. Functional MR gets a lot better when you take away the AI. Taking away AS often doesn't have a huge impact on a lot of functional MR. Okay. So AS severity, as MR gets worse and you have lower systemic stroke volume, the AR gradients get tougher. So this is sort of just summarizing what that case was. MR and MS does coexist. We don't see a ton of that. It tends to be senile degenerative when we get it. It can obviously happen with rheumatic. That's a little easier. Usually it's the stenosis that's dominant, at least the patients we see, and there's some MR. It's usually not difficult to quantify the MR, so the quantitation is not challenging. The MR combined with rheumatic MS is a problem because it can take away your balloon valvuloplasty option. If you have more than mild to moderate MR, that's really a contraindication to balloon mitral valvuloplasty for rheumatic MS. But think through the stages of MR, right? You have an acute insult, which is the top right. You increase your forward or your backflow. You quickly increase your LA pressure. You quickly decrease your forward stroke volume. You have a compensatory phase over time where the LV dilates. You have remodeling. Your LA remodels, so the pressure actually for the same backwards volume, the LA pressure goes down. Because you have LV remodeling and enlargement, your forward stroke volume actually goes up and can approach normal. And this is sort of this can be this fairly long chronic compensated phase, but invariably, and this is where the art is trying to figure out when, you become decompensated. You hope to intervene somewhere before this happens. But the decompensation is when forward stroke volume goes down, LA pressure goes up, and you start to feel bad. All this to say that again, the chamber that's seeing MR initially is the LA. When it's consistent and severe, it's the LV. But when it's MS, it's just the LA. Right? MS protects the LV and everything else. MS takes out the LA, the pulmonary veins, and then the right heart. So it all goes backwards. So looking at these other things. So again, this is part of the mixed valve conversation. How do we approach these things? Well, you look for what chamber has taken the damage from this lesion. On the left side is a severely enlarged LA. There's a short list of things that do that: MR, HFpEF, liver, ESRD, AFib. That's sort of the common list of things that will give you a reasonably enlarged LA. The massive LA, the 400 or so, and I think Carlos recently had one on Twitter that was like a liter. It was insane. Almost always MSMR. So the combination of volume and pressure is very commonly, if you've got an LA over 400, not always, always in medicine, but that's very likely to be MSMR. That pressure volume combo gives you an enormous chamber. And then kind of wrapping up, we do see combined lesions, single valve. This is a physician, retired, referred to us for MitraClip. He had calcium, he had stenosis, he had regurgitation, kind of an ugly valve. We ended up doing a successful clip on him. But even then, again, mentioning the pulmonary veins care. So this was S-wave inversion at the beginning, his baseline. So if pulmonary vein should always be forward and draining, his S-wave was inverted with a combination of mostly MR with a little MS. But even after 2 clips, S-wave resurrection, symptom resolution. MR and TR often coexist. Sometimes when they're both functional, you can have a little bit of improvement in the MR or the TR from a mitral intervention, but it's often a little bit underwhelming. The massive improvements in TR often come from GDMT. We've seen this over and over and over again, very volume dependent. So appropriate GDMT can have a big impact on functional TR. This is the same patient, and it's amazing that these valves were coexisting with this level of severity. Okay, so mixed valve disease, AS and AR, think volume and pressure load. AS and MR can be tough to quantify. The MR can be augmented by high LV pressure. So the MR actually looks a little worse because of the AS, and the AS is tough to quantify because of the loss flow by the MR. So those two can make a diagnostic challenge. MR and MS can give you very, very enlarged LA, and then MR and TR often coexist. So the perspective matters. So as you approach mixed valve disease, think about the pressure effect, think about the volume effect. Really this is to say, what is the ventricle seeing? Extra volume, extra pressure, or both? Is there evidence of chamber remodeling that's sort of out of keeping with what you'd expect from one lesion alone? And then, particularly when you involve the mitral valve, what are the pulmonary veins saying? Dominant S waves or not? Okay, and then we'll go to CMR. Over to you, Deepan.
Steve?
Dr. Q.
Yeah. Mike? Mike to Mike. Thank you. Hello? Yeah. So since we're going to have the CMR, I think this is what I'm going to talk about very appropriate for the CMR evaluation, because through my years of practice, one of the combinations that you did not address, and it's okay because it's a pain in the you know where, most challenging is when you have AR and MR. Because now the problem is you may have a 25% regulated fraction in one valve and a 30 in the other one, but that ventricle is hitting 55%. And it's a real challenge because neither valve looks that bad, but the combined volume load is phenomenal. And you scratch your head 20 times deciding how do you approach it, which valve do you fix. Maybe if you fix one, then you leave the other one with a minor lesion, and that's better. That's usually what we end up doing. If you're going to go to surgery, then you have to, you tackle both. I mean, that really is a big headache, and it's not uncommon. And I think CMR clearly can help you there, because at least we can get some very good numbers. It doesn't give us a solution, but it gives us numbers that then we can all discuss about. So I wanted to bring that lesion because that is not an uncommon lesion and a real headache in deciding how to manage.
I completely agree. In our valve clinic, we have quite a lot of AR, and Carlos texts me angrily most Tuesdays because he has to pre-read all the AR. And he says, why do you keep getting me AR and not MR? It's for exactly that reason, that the AR is very tough to quantify with a mixed valve dysfunction. And so we send that to CMR and make it deepen in Carlos's headache.
All right. Okay, so let me move forward here. What I thought I would do is start off with a case. And so here's actually a gentleman who was referred to us for severe MR for mitral clip evaluation, 75-year-old, hypertension, hyperlipidemia, COPD, AFib. So one of the things you'll probably notice if you looked at the cases that Steve presented as well as the cases that I'm presenting, there's a certain theme here in mixed valve disease, which is these are elderly patients with a lot of comorbidities as well. So keep that in mind as well. The issue, obviously, as the population is aging, we're going to see more and more of these patients. Here's what our final reports said. Here's severe AR, the AR volume, the AR fraction, the mitral regurg was, let's see. Okay, let me try. But resurrection is coming. Okay, there we go. Okay. Yes. So here's what our final results were, and then this, obviously also very important, is to look at the remodeling of the ventricle. So we've got the LV volumes, LV ejection fraction, and then also the RV. But let me go through and talk about how we got there, right? So that final result, because I think it's important for us to understand how to approach these. And I think as Steve talked about, you really want to take this kind of one step at a time. So obviously important is to assess the severity of each lesion that you're dealing with, look at the consequences of that lesion on the chambers of the heart, and then important to recognize also some of the pathophysiologic effects when you have mixed lesions, and I think Steve already did a very nice job of talking about the effects when you have severe MR is going to lead to low flow across the aortic valve, and a few other things that I'll touch on. And then also recognize, I think be aware of kind of imaging pitfalls and caveats as well. And at the end of the day, you have to recognize if you can't give an answer, it's okay once in a while. You can't do it all the time, but there are times when you're going to be able to say, hey, I just cannot come up with an answer here. But hopefully it should be not too often. So let's go through and talk about this with a quick recap of how we approach isolated valve lesions first. Because again, if you're talking about, I think of mixed valve disease as kind of like a graduate level course. So let's go through the 101 and 201 courses first. So how do you approach isolated valve lesions, whether stenotic or regurgitant? I think to recognize there's quantitative methods that we use, and then there's also semi-quantitative methods as well. And what I mean by that, so for aortic regurgitation, obviously, the preferred way is to try to directly quantify the severity of the regurgitation, where you can do a phase contrast imaging plane above the aortic valve level and measure then what the direct retrograde flow is in diastole. So that's a great method because you've got a direct single assessment of what the direct aortic regurgitation flow is. In some cases, though, we have other methods that you can use as well, where you can compare the LVOT forward flow to the pulmonary artery net flow, or in isolated aortic regurgitation, compare the LV to the RV stroke volume. And then for semi-quantitative approaches, there's also looking at the size of the regurgitant orifice area. So with aortic regurgitation, there's data showing that a regurgitant orifice area of more than 0.28 centimeters square has pretty good sensitivity and specificity for 3 or 4 plus AI. So in cases where you say, hey, I can't quantitate the severity, but I can get a general assessment of how bad the lesion is just simply based on the size of the regurgitant orifice area. And also you can look for holodiastolic flow reversal in the descending aorta. So just like you would in echocardiography, we can do the same thing in MRI. And it turns out actually that the plane that we use for our phase contrast in the ascending aorta actually gives you a very nice view of the descending aorta as well. So you can simply draw an ROI and see if there's retrograde holodiastolic flow in the descending aorta. Now for mitral regurgitation, again to recap, the general approach that we take here is to compare the volume of blood ejected out of the left ventricle to the volume of blood going forward across the aortic valve. And that difference in an isolated lesion is going to represent your mitral regurgitation. But also, the kind of semi-quantitative approach would be to look at the size of the regurgitant orifice area for the mitral valve. And again, this is using our cine images, but we have to make sure that you've got several cuts that allow you to identify the regurgitant orifice for the mitral valve. And an anatomic regurgitant orifice of more than 0.4 centimeters square has fairly good sensitivity and specificity for grade 3 or 4 plus mitral regurgitation. And then obviously for aortic stenosis, really you want to do two things. And again, all of this has been touched on in earlier lectures, so this is just a quick recap. You want to look at what is the velocity across the aortic valve, and again, that's measured by using our phase contrast CMR technique. But then also separately from that, measure what's the anatomic orifice area, and this is done using your SSFP cine images. So you get two independent measures that are not derived from each other to look at the aortic valve velocity and gradient as well as the anatomic aortic valve area. So now, as we put this all together, I'm going to bring you back to some basic concepts because these become very, very important when you're talking about mixed valve disease. And so really principle one is that there is this conservation of mass or conservation of flow. So whatever flow you have that's going through the tricuspid valve, that's going through the right ventricle, through the pulmonary artery, through the LV, through the aorta, should be equal, right? There's no reason why you should have more flow in one chamber, more flow across one valve than the other. So in the absence of any lesions, LV stroke volume should equal your RV stroke volume, should equal your aortic flow, should equal your PA flow. And importantly, we want to make sure when we're doing a mixed valve disease case, measure in each of these chambers. So try to get as many measurements as you can, because that will allow you to then be able to solve, to say what are the abnormalities in each individual lesion. Now, so I'm going to just harp on this point because, again, this is a point that I think is very, very key. So when I measure the flow crossing the aortic valve, or the LVOT, what is that measured flow actually composed of? So there's two components. What are those two components? Right, so it's your net forward flow. So not stroke volume in the sense of not the LV stroke volume, but it's the systemic flow plus the recirculating aortic regurgitation volume. Okay, so that's what your LVOT or aortic flow is, the systemic flow plus the regurgitant flow across the aortic valve. Same principle if you apply it to the right side. Just change it from the left ventricle to the right ventricle to say RV outflow tract or the pulmonary artery flow. And that equals your systemic flow plus your pulmonic regurgitant flow. Now, what about, what are the components that comprise the LV stroke volume? And my animation kind of messed up here and I gave you the answer. But remember, there's 3 components to the LV stroke volume, right? It includes the systemic flow plus the aortic regurgitant flow, which is recirculating, and the mitral regurgitant flow, which is recirculating. So as long as you know that when you measure, because we're measuring LV stroke volume or we're measuring forward flow across the aortic valve, know what the individual components of those are, because you'll use that information to try to solve backward to figure out what's the severity in each lesion when you've got multiple lesions that have abnormalities. Okay, so let's go forward here. And then let's go back to this case. So again, this was a case, was referred for mitral clip evaluation because of severe MR, but it turns out there's also an aortic regurgitation jet as well. And let me go through and show you kind of how we approach this case. So first thing we did is, so again, pick one lesion, try to solve that first, and then go to the next lesion. Generally speaking, if you have mixed AR and MR, I always like to start with the aortic valve first. So let's try to figure out what is the aortic regurgitant severity. And again, as we talked about, if we simply measure in an imaging plane above the aortic valve, like I've got here, I can actually measure what the direct retrograde flow is. And in this patient right here, I've got a direct retrograde flow of 70 cc's. So that's 70 cc's of aortic regurgitation. Now, you always want to get corroboration of that. And so what I also will do is measure what is the forward flow crossing the aortic valve. Because again, going back to that conservation of flow principle, if I have aortic regurgitation, that is going to increase my forward flow across the aortic valve compared to my systemic flow or compared to my pulmonary artery flow. So in this case, I could see that the forward flow across the aortic valve is actually 127 cc's, and the pulmonary artery net flow is 49. So again, if I look at the difference between these two, that comes up with 78. Now obviously each technique is going to have a little bit of variability. I've got 70 by one approach, 78 by another, telling me this is severe aortic regurgitation. So I've got that solution answered. I corroborated that even further by saying, let's look at the size of the anatomic orifice area. I got a 0.4 regurgitant orifice area, also telling me, giving me even more confidence that I'm dealing with severe aortic regurgitation. So now I've got aortic regurg assessed. Now let's go to the mitral. And again, how would I determine the mitral regurg severity here? This person has AI, but I've determined what the AI severity is. How am I going to determine the mitral regurgitation? Somebody.
Subtract from the LV stroke volume minus the total AR and the systemic forward flow.
Okay, so which one is it, AR or systemic forward flow?
Systemic forward.
Right. So think about it. I mean, because what you're going to have here is the LV stroke volume, right? Just by contouring LV end diastole and systole, I get the stroke volume of the ventricle. What I have is I have the forward flow across the aortic valve, right? If I just, so the same equation that I use for isolated mitral valves works in this setting as well. Because if I just take the LV stroke volume minus the forward flow across the aortic valve, and the reason is because the aortic regurg, remember we talked about it adds to the aortic forward flow, right? But guess what? It also adds to the LV stroke volume as well. So the two cancel themselves out. So this equation of comparing the LV stroke volume to the aortic forward flow works even in the setting of aortic regurgitation. So in this case, I had a planimetered LV stroke volume of 192. 127 was going forward across the aortic valve. Therefore, I can then determine that the mitral regurgitation is 65 cc's. Now, one thing here where there's different approaches, right? And here's the approach that we use in MRI, which is if I'm going to determine the regurgitant fraction for the mitral regurgitation, I'm not going to take the mitral regurgitant volume divided by the LV stroke volume, because that includes the AI as well. If I do that, the mitral regurgitant fraction will always be very, very low, right? And it will change based on how much AI you have. So instead, the concept is you want to say the mitral regurgitant fraction is really the reverse flow of the mitral valve across the forward flow of that valve. And the way that you can determine the forward flow is by taking the LV stroke volume minus the AI, right? That's what tells you what the mitral forward flow is. So in this case, you've got 53%. Now, if I didn't do it this way, I'd get a regurgitant fraction of 30%, and the point that Dr. Q raised looks like severe lesions, but I'm only getting 30% for each. So, yep, go ahead. Pardon me? So, no, and the reason is because, remember, the RV stroke volume doesn't incorporate the mitral regurgitation, right? Because again, if the concept is that the regurgitant fraction is the reverse flow over the forward flow, I do need to incorporate the mitral regurgitation into that. And then obviously in these cases, the reason you want to try to do it as close to the lesion you're of interest is because there may be TR, there may be PR as well, which would affect the RV stroke volume. So the idea is you can go further away from the lesion of interest, but try to stay as close as you can, because as you go further away, you have to make assumptions that there's not other lesions elsewhere.
But, I mean, I understand what you're saying. In fact, it does make some sense, but it breaks the traditional use of these terms. So that would confuse clinicians ordering tests, because the traditional concept is the LV ejects, let's say, 190 cc's. Let's say 70 are going one way, 70 are going the other. It's still the percent of the total LV stroke volume being lost by one lesion or another. So, it's not really a big deal if it ends up being 39% for mitral. The combined loss is tremendous.
Yeah.
And that's the way it has been done for 40 years. So now you introduce a different equation, which we could discuss it and maybe even agree that it has some sense, but when you throw that in a report, it will throw away, it will confuse a lot of people.
Yeah.
So I take some issue with that concept, because to me, it's still, the regurgitant fraction is what percent of the total stroke volume is being lost. Because I'm thinking the work the LV is doing, the LV is having to do X amount of work because it's losing X percent in one valve, Y percent in another. Now you're making it in a way that it's, it just,
So I'll tell you.
it changes the whole conceptual approach
obviously,
to regurgitant fraction.
Obviously, this was something that we had discussed in the ASC valve guidelines in 2017, because I was involved in the section on writing the mixed valve disease section, and this is actually what we had put forward. And so there's a table in there which actually shows exactly this approach. Now, I think part of it is obviously, traditionally in the past, people had not incorporated this approach because you had a hard time quantifying your AR as well in the setting of mixed valve disease. But if you think about it, otherwise, if I've got a certain amount of aortic regurgitation, or I've got a certain amount of mitral regurgitation, the regurgitant fraction will be affected by the severity of the other lesion, and it'll keep making it less and less. If I get more AR, the MR fraction keeps getting less and less, right? So again, if we keep our same concept of what is severe, your concept of saying I'm looking for 50% regurgitant fraction, this actually gets you closer to that approach than I think if you start to divide it by the total LV stroke volume.
That's going to take a while to train doctors on that one, I can tell
Yep.
you. Because for years, the concept has been RF is a measurement of the load to the ventricle. So if you think in terms of LV, which is the way I have thought for years, it's what percent of the total volume is being lost in one valve or another. The way you are approaching it, I'm not saying that necessarily is wrong, but it's a different approach. And it's going to take a while to train docs on that.
No, and this is something that, we thought about this for many, many years ago. I'd been reporting it this way from the very beginning because we have the ability to identify each individual component. And I know we discussed this also in the ASC valve guidelines as well when we came up with that document. But I think, again, otherwise I think the reason I highlighted this point is because I think it's very important, because otherwise you're going to have cases where they're all going to be mild or moderate lesions at most. You'll never get too severe lesions, even though you've got a huge amount of flow crossing each valve, because you're indexing it to the combined load of both lesions, right?
I know the ASE, we put it as such, but going back to the previous question, you're forcing to use only mitral inflow to calculate the total volume coming through the mitral valve. Okay?
Yeah.
There is another way, actually what he suggested was correct, is if I have systemic output in the pulmonic area or net, whatever it is, you add regurgitant volume to it, that would be your denominator. And the regurgitation is your numerator.
Yeah. So there's many
Meaning
different.
that you don't have to, if the technology doesn't give you the best technology to look at mitral inflow by MRI, you could use pulmonic flow that is systemic. You add pulmonic to regurgitant volume of the mitral, that would be your denominator, and the regurgitation is your numerator, and this is how you calculate your regurgitant fraction, isolating one valve.
Yeah,
You with me?
and obviously the reason I said that the approach of looking at the RV stroke volume is because that works as long as there's no TR or no PR, right? So, but again, why not just go with the LV stroke volume, which is sitting right there, because that, and then just subtract out the AI. See, in other words, there's just different ways that you can do it, but as you get further and further away, you have to make assumptions that there's not lesions in the other places. In this case, you know what the...
Mitral inflow, calculating mitral inflow.
Right, so that's basically your LV stroke volume minus the aortic regurgitation. We don't actually do the direct mitral inflow calculation. We use the LV stroke volume minus the aortic regurgitation to do that, right? What I'm talking about is conceptually, right? It's conceptually the flow crossing the mitral valve, right? So the question is, what's the best way to determine that? The closer you are to the lesion to determine it, the less assumptions you have to make, right? As you go further away, you have to assume that there's no TR, no PR, or something else, right? Steve, you had a comment as well?
Just to make sure I understand this, and sort of echoing Dr. Q's comment, so if there's no AI, you've got the classic LV regurgitant fraction, which is the
Right.
In the setting of AI, you introduce really a mitral valve regurgitant fraction.
Correct, because we call it mitral regurgitant fraction.
So it's mitral regurgitant fraction. So
Yes.
without AI, they're the same number.
Correct.
And with AI, they're different numbers.
No, it would say the same, because in other words, let's say I have a patient who's got mitral regurgitation. They have a certain, if all of a sudden now you introduce a bunch of AI to that patient, if in the older approach, if you divide it by the LV stroke volume, that incorporates the AI. In this case, if you don't incorporate the AI,
LV regurgitant fraction in the classic sense. So if you did the
Right.
classic way, you would have a different number at that point.
correct. But whereas this way, it doesn't change. If the other lesion severity changes, as long as the flow across this valve doesn't change, the regurgitant fraction for this valve doesn't change, right? Okay, so, and then I think the other thing is that the regurgitant, you're not going to get this artificial underestimation of the mitral regurgitant fraction, right? Compared to the amount of volume that you have coming across here. Okay, so let's go, so this case, so in the end we came up with severe AI, severe MR, and then what the regurgitant severity of each was. And then obviously, as we talked about before, important to look at the remodeling of the ventricle as well. And then, let me skip forward here to the next case. So the basic principle here again is that if you have mixed MR and AR, the way that you do the aortic regurgitant volume is just by the standard approach of measuring the reverse flow in a phase contrast plane above the valve, or you could do the indirect flow approach of measuring the forward flow across the LVOT to the pulmonary artery net flow. And then your regurgitant fraction is done the standard approach, reverse flow across the forward flow across the aortic valve. For the mitral, would be, again, the regurgitant volume would be calculated the same way, which is LV stroke volume minus forward flow across the LVOT. But then as we talked about for the mitral regurgitant fraction, since conceptually you want to know what is the forward flow across the mitral valve, which you can derive that by the LV stroke volume minus the aortic regurgitation. Now, a couple other caveats to keep in mind. Obviously, this, if you have right-sided lesions with this approach, TR or PR don't have any effect, right? So with these equations work just as well no matter how much TR or PR you have. And the reason I say that you want to try to stay as close to the lesion of interest as possible, these patients often will have multiple valve lesions, right? And so I would bet you every single patient I've seen who has significant MR and AR also has some TR and also has some PI as well. And then obviously the way that you would do the TR and PR assessment will be the same way analogous to what we talked about here for the left-sided valves. And then another thing to keep in mind is in the setting of AFib, your direct aortic reverse flow that we try to measure above the aortic valve may not be as reliable. And so that's where you rely more on looking at the systolic forward flow across the aortic valve to the pulmonary artery net flow. So again, use all the tools that you have in the toolbox to try to solve these equations. And then if for whatever reason your phase contrast doesn't work at all, sometimes you have to just say, look at what is the total regurgitant load that you have, which is simply going to be the LV stroke volume minus the RV stroke volume, as long as there's not other RV lesions. And you can just report a total regurgitant load, which in this case combines to 132 cc's. Okay, so let me skip forward here to the next case. Oh, I'm going the wrong direction. Sorry, guys. I was like, these slides look very familiar. Okay, so next case we've got is one where we have mixed aortic regurg and aortic stenosis. And that's coming up. 1 second. Yeah, I'm just... And so here you've got a patient who you can see from your mitral regurgitation, you can see there's a color flow jet here in the left atrium. And there's also reduced opening of the aortic valve, as you can see. So there's a mixed AS-MR case. And in this case, if I look at this, there's a trileaflet valve. When I measured the velocity across the valve, there's a peak velocity of about 3.5 meters per second with an anatomic valve area of 1 centimeter squared. But now if you look at the mitral regurgitation, here there's a couple of caveats, right? Which is, if I want to measure the flow coming across the aortic valve, it's not ideal to measure distal, right? Because you're measuring it distal to an area of flow turbulence, and you may underestimate on your phase contrast technique. So as a result, because you always want to measure flow in an area where the flow is much more streamlined and laminar. So in this case, it's preferable to measure the flow in the LVOT, so proximal to the obstruction, proximal to the stenotic aortic valve, to determine what is the flow going out. And then for my LV stroke volume, I can determine how much is being ejected by this ventricle. In this case, the ventricle ejects 100 cc's, but the forward flow across the aortic valve was only 80 cc's. So there's only 20, or was 80, so there's only 20 cc's of mitral regurg. And again, this is one of those things that oftentimes on color, remember, the extent of the color can appear more when you're dealing with a higher velocity. And if you have a mixed AS-MR jet, that MR jet is going to be a higher velocity jet than in the absence of the AS. Okay.
How do you exclude AI?
So yeah, for excluding AI, the best way would be to look at the forward flow across the LVOT to the PA net, flow. Oftentimes, we'll also measure the flow in the ascending aorta here. And the reason is you have flow turbulence during systole, but oftentimes that the kind of dephasing that you have goes away in diastole. So most of the time in these cases, even if you measure a distal, the diastolic reverse flow is still reliable. But you have, in those cases, really looking at the LVOT to the PA is the preferred way for AI assessment. Okay, so let me skip past here. And this is just kind of showing a mixed AS-AR case. And here again, you're going to try to measure what is the velocity across this valve. So here you've got 4.75 meters per second. The anatomic area of this valve is 1.0 centimeters squared. And if I measure the forward flow across this valve, this again is for looking at the AI assessment. So I'm going to measure LVOT forward flow, which is 105 cc's, compare that to my PA net flow, which is 53 cc's, telling me that there's quite a bit of aortic regurgitation in this case. So here you've got a lesion, and the way that you approach mixed AS-MR is for the aortic regurgitant volume, again, measure it proximal to the aortic valve as opposed to distal. and then compare it to the PA net flow. For the aortic regurgitant fraction, it's using the standard approach. And then for the AS assessment, you're going to do a velocity and gradient approach with phase contrast, and then do an anatomic area approach separately by measuring the anatomic valve area. So conclusion, I think the most important thing when you're dealing with mixed valve lesions is to, one, understand what effects each lesion has on this kind of conservation of mass principle, to say each lesion, which, when there's a lesion at one particular valve, what does it affect as far as stroke volume or flow across which valves? And then again, going back to those initial equations that we talked about, which is that your flow across the great vessels really is comprised of systemic flow plus the regurgitant flow across that great vessel valve. Whereas for the LV or RV stroke volume is composed of three components. It's a systemic flow plus the regurgitation of both the AV valve as well as regurgitation of the semilunar valve on that side. So with that, I thank you for your attention, and then we'll open it up for any comments or questions. And Steve, if you want to come on up as well.
We can talk
Doctor?
about it.
Yes, yeah.
And in reality, you always start with the echo.
Yes, you start with the echo, and then you get the final answer.
Drop the mic.
For AR lesions, like you said, for AS lesions, the flow is measured.
Yeah, use a mic, please.
For stenotic lesions of the aortic valve, you mentioned that we measure the flow below the valve and for regurgitant above. So is there a reason the regurgitant volumes or flows cannot be measured below the valve?
Well, no, so they can be, but then you have to do is compare the forward flow to a different, chamber, so compare it to the pulmonary artery net flow. Now your question is, could you not measure the direct reverse flow? Right, the problem is, what if the jet's very eccentric, right? So sometimes that approach of saying in the LVOT, can I see the AI jet coming down and just directly measure that? Sometimes it works, but if you have a very eccentric jet and you're trying to measure it in a particular plane, it's going to underestimate. Yep.
Measure flow in a high velocity jet
Flow,
not gradient flow.
right. You can, but it may underestimate because of the, yeah, right. Yeah, I mean, that's why you don't rely, in other words, you don't want to rely at that location, you want to rely proximal to that, yep. Okay.
Outstanding work.
Any other? All right, thank you all.